Hello, my dear friends. I'm myself Dr. Rajesh Guba. I'm a cardiologist and I'm also the mentor for entrance exams like NEET PG, PGI Chandigarh, JIPMER, and as well as AIMS exam. So I teach general medicine in the following exams and I welcome you all to my daily dose. So in this particular daily dose, I have come up with this particular clinical question, that is, I have a 60-year-old man presents to the emergency department with 3 days history of increasingly severe chest pain. And the patient describes the pain as sharp, tearing pain starting in the center of his chest and radiating straight through his back between his shoulder blades. The patient looks in pain, but there is no pallor. Heart rate is around 95, respiratory rate is 20, temperature is around 37 degrees centigrade, and the blood pressure is 155 by 95 millimeters of mercury. What is the most likely diagnosis in this patient? The options given are myocardial infarction, myocardial ischemia, aortic dissection, pulmonary embolism, pneumonia. Now, so you just take the character of this particular pain. So the character of the pain, what has been described in this question is, it is radiating pain, it is sharp tearing pain. And where is it radiating to? It is radiating between the shoulder blades. That means the pain has started anteriorly and the pain has radiated posteriorly. First of all, you should imagine any particular structure which is starting anteriorly then progressing posteriorly. So what is that structure that should come to your mind? That is nothing but your aorta. So aorta, if you see ascending aorta, it is present in the anterior mediastinum. Then arch of aorta and as well as descending aorta, it is present in the remaining parts of your mediastinum. So your aorta is anatomically, it is moving or it is progressing from the anterior mediastinum to your posterior mediastinum. And you see the pain also. The pain is present anteriorly and it is progressing posteriorly. Right? So you have to think a disease in this particular patient related to aorta. So what is that option which is related to your aorta? That is your aortic dissection. So aortic dissection, you will have tearing type of pain which is radiating posteriorly between the blades of the scapula. Right? Now, how to rule out the other options? Like you take the myocardial infarction. See, in myocardial infarction, see, this particular patient is having pain since 3 days. But in myocardial infarction, it is acute onset of pain. Right? It is acute onset of pain. And definitely, yes, the pain will be of more than 30 minutes. Right? Pain will be of more than 30 minutes in patients with the myocardial infarction. But it is acute in onset. The individual may not give you 3 days history of pain and there is no radiation between the scapular blades in patients with the myocardial infarction. So your myocardial infarction is ruled out. Whereas you take myocardial ischemia. See, you take in patients with the myocardial ischemia. So what is that you can have in patients with myocardial ischemia? You will have what is called the anginal pain. Right, you will have what is called anginal pain. Now this anginal pain, it could be like seen in patients with stable angina or seen in patients with unstable angina. In patients with, okay, before that, you take what will be the characteristic feature of your anginal pain. Let me explain you. So this should be, the pain should be of retrosternal in origin, and it may radiate to your left arm, it may radiate to your jaw, it may even radiate to the right side, right? Radiation will be there, but the origin is retrosternal. And what will be the characteristic feature of the pain? It is crushing pain. Right? It's a crushing pain. Okay? Or the individual will explain you that there is heaviness of the chest. So it is retrosternal in origin. Number 2, the character is crushing or heaviness over the chest. And this particular pain is relieved by taking rest or by taking sublingual nitrate. Right? By taking sublingual nitrate. So these are the features of your anginal pain. Right? In case of stable angina, the duration of the pain is around 2 to 10 minutes. And in unstable angina, the pain will be more than 10 minutes and it progressively increases. Right? It progressively increases in case of unstable angina. But here, in any of your anginal pain, the pain will not progress into the scapular areas, right? In between the scapula, it will not progress in case of your anginal pain. So that is the reason why even your myocardial ischemia is also ruled out. Whereas you take pulmonary embolism, yes, they will have chest pain, but they will have chest pain which increases on inspiration, right? So that is pleuritic type of chest pain these individuals can have. But that is not being described here. And that too, the pain will be more or less acute in onset. And even you take in patients with pneumonia, they will also have pleuritic type of pain. That is, the pain, it will increase on inspiration. So from the options given, we can rule out all other options and we can fix the answer in this particular patient as aortic dissection. And let me show you a table which is directly from the Harrison. So the pain of cardiac origin, it could be of myocardial ischemia or pericarditis. Ischemic pain, just now I have discussed, that is your anginal pain. You take the pain of pericarditis. Pain of pericarditis, it will be a very sharp pain and it is a pleuritic pain. That means the pain will increase on inspiration. Whereas you take vascular pain. Vascular pain, it could be because of acute aortic syndrome. Acute aortic syndrome is the one where the individual will have tearing pain which is sudden in onset. Right, and that will progress from anterior part of the chest to the blades in between the scapula. Pulmonary embolism I have discussed, and pulmonary hypertension also, there will be exertional pain, right? The pain will increase on exertion, right? And pulmonary origin, pneumonia, pleuritis, already I have discussed, like what will be the character of the pain. But you take the chest pain of gastrointestinal origin, most of it will be of burning in nature, and this particular pain will increase after taking food, right? So that will be of gastrointestinal origin. And you take the neuromuscular pain, like you take in case of costochondritis, it is aching pain and the location is in the sternum. Okay, and psychological pain, it could be because of emotional onset and as well as psychiatric conditions, right? And the quality is variable, location is variable, everything is variable because it's psychological. So going back to the question, the answer here, because it is the tearing quality radiating straight into the back between the shoulder blades, that is why the answer is aortic dissection. See, depending upon the quality of the pain, depending upon where it is radiating, depending upon the duration, you should be able to differentiate the underlying etiology of the chest pain. So this particular MCQ was completely to discuss the various types of chest pain. So I hope you might have enjoyed this particular short video. So to get updates on daily dose, please follow our channel. Thank you very much.